your body has to fail on me for something bad to happen, which means I don't want to have a heart attack. I don't want to have a stroke. That means that your heart has to have a functional problem for that to happen.
You know, I think the interesting part is there are a lot of myths that surround anesthesia. And I would say that most of our patients, their number one fear, it's not the pain afterwards. It's not the recovery associated. It's not how they're going to look, but it's the anesthesia. Before we delve into that, I think maybe why don't we get a little background about yourself? How did you find yourself into the field of anesthesiology? And specifically, you know, when we talk about the context of cosmetic surgery, because obviously anesthesia has a large breadth of what you can do, and kind of bring us through what was your thought process?
Sure. I won't take you all the way back, but I definitely will. I knew at a young age I wanted to be a doctor, and through high school and applying to college, I was lucky enough to get a scholarship to go to school. I grew up in Southern California, went to USC, and even USC did such a great job immediately knowing that if you wanted to go into medicine, they set you up with mentorship programs. So you immediately were volunteering at the hospital and the ER doing research. And I ended up staying at USC for medical school as well. And right when you're in medical school, just as both of you know, you immediately start getting into the academic side and as well as the clinical side. Mm-hmm. I thought I always wanted to do surgery. I loved the OR setting. I loved anatomy. I loved to draw. I loved my mind really works in a three-dimensional space. And I just loved that aspect of medicine. While you start your clinical rotations, you start realizing that there is medicine and then there's the life of the doctor and how they practice medicine. Sure. And so I ultimately was acutely aware of how that was going to change my life. And I knew that I saw the surgeons and how they went at work, they operated, they had clinics, they had patients. And that was an interesting concept. And when I did my anesthesia rotation, it was different. It was different in the sense where when I was with the surgeons and I was in the clinic, I always remembered, wow, they are double or triple booked every 15 minutes. And I hated feeling that I was not 100% there for the patients. And sure. I had to rush from room to room. Mm-hmm. And when I started the anesthesia rotations, I realized I have one patient. And if that surgery lasts 1 hour or 5 hours, I'm there for them the entire time. And I really found that really enticing. And so I kind of, took that road.
That's interesting. I totally understand that. Obviously, as surgeons, especially in residency, you were cycling through as many patients as you could to try to glean that experience. And every now and then, you did feel rushed. I mean, the idea was you had to succinctly examine, evaluate, and treat a patient within a particular time period because there's more coming through the door. And so I totally respect that. When you're in residency, obviously, we have colleagues that are anesthesiologists in a hospital setting, in a pain management setting, in cardiac setting, and it takes a special person for each one of those. But I also believe that it takes a special person for cosmetic and aesthetic surgery because this is elective surgery. The patient is willingly undergoing the knife, and they need a specific type of anesthesiologist to make them feel comfortable. So how did you navigate your way from, learning everything to really saying, all right, this is the passion?
Yeah, that is a great question. Ultimately, when I see my day, and the reality is that you're right, these patients have electively come to our practice to do something that they would never have done in another arena. They're not in the hospital. It's not an appendicitis. They didn't break their arm. So they are willingly giving us their bodies and trusting us with their most important life. So yes, and for you, the surgeon, on your end, you've had weeks, days, sometimes months, sometimes even years to be able to talk and console those patients and walk them through the process. Mm-hmm. Even on the patient side, patient's doctor shop. They go from one surgeon to the next. They love your demeanor. They love your work. They love whatever it is for your referral basis. When I come into that room, I have 30 seconds to gain their trust. Mm-hmm. I have 30 seconds for them to say, okay, I know that I'm worried. I know that I'm scared, but I'm going to give you my most prized possession, my brain, my body, and you're going to do whatever it is you're going to do because anesthesia is a black box. And most patients, sometimes they come into these scenarios and they say, the first question they say, I don't want to die. I want to come home to my family.
Exactly. Yeah.
I have kids. I'm here to get my boobs done or my nose fixed or whatever it is. and nothing is worth leaving here in a different way. And so what is my role is to leave them better than I found them.
It's a perfect segue, actually, because a lot of our listeners are our patients and people have had surgery with us. And the one thing I've noticed over the years is not only did they give us praise, but they'll come back and say, your anesthesiologist was amazing. And we picked you, we hand-picked you. You are the director of anesthesiology in our surgery center and for our practice. And it's because we've worked with a lot of different anesthesiologists. And before we built our own surgery center, before we built our own, practice where we do everything in-house, we would go into other surgery centers and we wouldn't pick our anesthesiologist. Just like the patients got what they got, we would just get an anesthesiologist. And for the most part, board certified anesthesiologists do their job very well. But the difference is what you just talked about, what Dr. Layke just talked about, is making the patient feel so comfortable that not only, you find out more about our patients than we do sometimes, but it's amazing because you make them feel comfortable to the point where before they're going to sleep, they're not anxious. In an interesting way, you make them manifest their best result. And it really is great. Now, at the same time, the anesthesia is amazing. They go to sleep smoothly, they wake up smoothly, and that's really what we look for. But the extra, the personality that you bring in is the special part of being Dr. Loewenbein. And we appreciate that. Not everybody gets that. Not every anesthesiologist is like that. And most patients that have surgery, they don't remember their anesthesiologist. So whatever you're doing, my man, we appreciate it because it makes a big, big difference.
I definitely want to outline in detail some of the little things that you do that I notice that are different. And it's not to give away your trade secrets or whatever, but I think it's to help improve any of the other anesthesiologists out there, because we've dealt with different types of anesthesiologists our entire careers, and there are some that are truly special. And it's not just the way you treat patients, but it's the way the patients feel afterwards as well. And so we're kind of touch on that. You've treated thousands of patients. Obviously, you've been with us for 10 years. If you wanted to describe your thoughts on what people are actually afraid of when it comes to anesthesia.
Yeah, when you think about it, really, anesthesia is a black box. It is like this magical elixir that I put you to sleep. And really, what does that entail? It entails a lot of things, and I explain that to patients a lot of the time. So when they come to me and say, I'm afraid, and I can tell that they're nervous, I kind of just break it down for them. And I really kind of just take a step back and make it and simplify it. And I say, you're going to be amazing. I know you're going to be amazing. And just like you said, they have to visualize that. But when you really kind of take and kind of pick it apart, I say, I'm going to do three things for you. I'm going to take away your memory because you can't remember the surgery. I'm going to control your pain because I don't want you to feel ouch. And of course, the other third part of anesthesia, which is interesting, is muscle and movement control. Because just like if we were sleeping and you were in bed and your partner pinches you when you're asleep, you're going to wiggle or you're going to flinch. And of course, that's not great for a surgical setting when the surgeon's trying to operate in a calm environment. So you kind of just break that down. You say, and I am there with you the entire time, keenly aware of everything that's happening, constantly giving, constantly taking away, and making sure that you are your perfect self. And as my career has progressed, really kind of, without sounding too corny, less is more. This is an outpatient elective surgery.
You're right.
This is so different than an inpatient in the hospital surgery, where you know that there's a recovery suite and there's a overnight suite and there's an ICU and there's like 10 nurses that are going to be there for you because you're not leaving the hospital for 24 hours. I am only as good at, which is what you see, as my last anesthetic. How many times will a patient have a bad outcome until you ultimately say, you know what, you're not our guy anymore.
Yep.
The patient has to come in, get whatever it is that they're getting done, and they have to be able to, within a very short time, walk up, smile, and say, I feel pretty good.
Yep.
That was awesome. And so during that experience, I ultimately also have to make sure that they feel loved, that they feel taken care of, and that they know that the medical aspect, that's a non-issue. But the fact of being afraid of anesthesia and what is it that people are afraid of, it's because, television, movies, they sensationalize the errors of anesthesia, the tiny little percentages of the, wow, can I really be asleep and paralyzed and feel and hear? So that kind of comes to the point where I tell sometimes patients, I have to be so bad at my job that day. So like those 3 things I mentioned, I have to just say, nah, I don't really care about the movement aspect. Nah, I don't really care about the pain. I'm only going to put you to sleep and just kind of keep you under. And they'll say, well, can that happen? I say, well, it can if I was just literally out of the room or asleep or not, paying attention at all, because we have such amazing monitoring equipment nowadays that I literally have you, wired from head to toe. Your brain, your heart, your vital signs. And so I have to so disregard the blatant, obvious beeps and sounds and horns that, yes, I have to be really bad at my job for you to actually have a bad outcome. Yeah. Not that bad outcomes can't happen, but I really have to just say, I don't care.
Really interesting what you said, which is something we have to understand. When we're doing outpatient surgery, it's very different than a hospital-based setting. An anesthesiologist can give as much anesthetic to a patient that's having hospital-based surgery, and he'll be like, okay, they'll sit in the recovery room, then they'll go to a room and they'll be monitored. What Dr. Loewenbein's saying, we're done with an operation. They're going to get up and go home. Our patients don't go to the hospital. So there's got to be that perfect dose of anesthesia that you give to these people. So we get to really see how great these patients feel after, because they're not getting a ton of anesthetic. You've got that perfect balance of what you give them. It takes years and years of experience to get there.
It has. I mean, at the beginning of my career, you're trained for everything: cardiac anesthesia, neuroanesthesia, and I did a lot of outpatient anesthesia. I did a lot of anesthesia for pregnant moms, for epidurals. You realize that how important it is for the post wake up, the first 5, 10, 15 minutes. I can just give some medication and I can say bye-bye and walk out of the room, and the nurses deal with it. But that actually is not the best anesthesia you can deliver. For what you guys do in the aesthetics world, I mean, I need a patient, just like our 2 patients yesterday. Within 5 minutes of that surgery being done, they were awake and chatting, having a sip of water. They were ready to get dressed, and they were ready to just start their life.
And more importantly, they felt great at night. They
Correct.
Didn't have a ton of nausea or vomiting and things. And we'll get into all that post anesthesia sequelae. But yeah, it's really fascinating how you can take that hospital-based anesthesia that you've been taught and then alter it so these patients have the best experience.
I kind of alluded to it earlier, and that was the fact that there is a specific method you use to ensure patient safety and comfort. Okay, it's different for every anesthesiologist. Each one has their own method, and whether it's successful or not, you see at the end of the case. What do you do for either even twilight anesthesia or general anesthesia to ensure patient comfort and their safety?
When you think about anesthesia, whether it be aesthetics or non-aesthetics, but we can talk aesthetics today, you can do as little as local anesthesia with the patient awake, and then it kind of comes into a world of called MAC anesthesia, which becomes twilight, which becomes conscious sedation, which becomes general anesthesia. And so if you think about it from 1 to 10, where are we in that? And there's a huge gray area, and that gray area is the nuance of why one anesthesiologist is good and the other is bad. Because at the end of the day, the safety aspects of anesthesia are very simple. I am an airway specialist. I have to make sure that your patient is breathing, that their heart is functioning, that the brain is responsive. But at the same time, while that is my responsibility, everything that I give affects all of the parts of the body. So any anesthetic does affect blood pressure, does affect how blood is going to the brain, the heart, the lungs. And so, we have to adjust our anesthesia to the patient, because everything is completely tailored to the patient. This is not the old days of the sense of where the anesthesiologist walks in the room, throws a dart at the patient, picks up the newspaper, and then just comes back in the room when the patient's done. And so you tailor the anesthesia to the patient, but also have to tailor to the surgeon. And a lot of my anesthetics are different surgeon based, because some surgeons like different things.
Sure.
And so I have to do that. And so you create a concept of, this is what this surgeon likes, and this is how he wants it, and that's how he operates best.
I mean, think about it. Even when, let's say I'm doing a face and neck lift, and you control blood pressure, down to the number where I want to keep the blood pressure to avoid bruising and bleeding and things like that. But obviously then you gradually bring it back up as opposed to, reversing and causing issues. I always marvel at that because, there are a lot of moving parts, and you are constantly looking, evaluating, and adjusting as necessary.
And I know that I do that for aesthetics. I do a lot of spine surgery as well. And it happens a fair amount of the time where the spine surgeon looks at me and goes, "That was great." And he knows, because he's like, there was no bleeding. His visual field was clear, where he can actually operate, and it saves time, and it saves just, less manipulation of the surgical site. And I think it was a month ago. I think we had 3 spine surgeries back to back to back. And on the third one, he goes, "I don't want to jinx it, but like, this was amazing." And he goes, "What are you doing?" And the reality is that at a certain point, it's like, one, I'm caring, right? I'm actually paying attention. Mm-hmm. And I just know that I need to perform at the highest level for the surgeon to perform at the highest level. Because at the end of the day, the surgeon, and not that I'm disregarding the surgical knowledge of anesthesia, they don't know what I'm doing.
Yeah.
And that's very true. And it's interesting because we have a lot of patients that come in, and I know this happens on a daily basis. I don't want to go to sleep, or I don't want general anesthesia, or the guy next door is doing this while I'm awake, or, "Hey, can you do this so I don't have to have a breathing tube?" And there are all these questions because nowadays, unfortunately, I don't want to call it a gimmick, but there's so many different ways people are doing things. People are doing facelifts under local. They're doing breast dogs under local. I want to kind of dispel this fear, because there is this fear with anesthesia. That's why they're doing it. And I've always said the same thing to people. I've said, malpractice insurance for an anesthesiologist is probably the lowest for most practitioners because it's a very safe practice. Please just educate our viewers that going to sleep or getting anesthesia or getting general anesthesia is not something that should be so fearful about.
Let's think about why that patient is afraid and why the fear is, they say like, I had a bad story from my aunt, from my mom, from some family member that something happened during anesthesia. And a lot of times I tell patients, sometimes while we try to control everything in the operating room, things are uncontrollable and bad things can happen. Mm-hmm. And while they're being very rare, we have to be realistic with the patients. Not that everything can be puppy dogs and rainbows, but at the same time, that education becomes the verbal speech of, sometimes I tell patients, your body has to fail on me for something bad to happen, which means I don't want to have a heart attack. I don't want to have a stroke. That means that your heart has to have a functional problem for that to happen.
And we make sure prior to getting into surgery.
Exactly.
So we'll talk about that in a minute.
So we take utmost care for our patients from the first time they walk in the door from the consultation to the pre-op experience to by the time they get to the actual room and the table, where we know that they are there in their optimal shape that they can be. So when a patient is finally ready for on the surgical day and they're still afraid, like, yes, something innate with their body sometimes has to happen. Now, can I create that badness by something that I'm doing? Sure. Because most of the problems...
You're disrupting the milieu. You
Correct.
can do it at any point.
Correct.
So.
Most of the problems that happen in the operating room based off of anesthesia are usually human error. We have to take ownership of that, which is why I take my role so seriously, where it says, like, you guys see me, I am a little bit OCD. I am perfect. Like, all my everything has to be in order. Like, I don't bring a patient in. I'm not ready for surgery until I'm ready for surgery, which means that everything's calculated, everything's drawn up, everything's weight based. And these are the things that you probably don't really see, but that is actually what's happening. Mm-hmm. And so if I create an error or something were to happen to a patient, it might be me. And so I have to take that knowledge and take that incredibly serious. So that's why when we say, like, they have to trust me within 30 seconds of knowing me, it's something the patients say, like, I never met my anesthesiologist. You guys say, like, oh, your patients love you. I know they love you. They love me because when I come into the office and they see me, they hug me.
Yeah.
And they bring you gifts.
Well, right. I mean, they're wonderful, but I mean, that's not happening a lot of the times. And so I take most of my patients under my wing as my family.
So we've all had procedures. I had a colonoscopy not long ago. I don't remember the person who gave me propofol. Right. I don't. I really, really don't. And it's a gift that you have. But it's interesting what I asked you. So the listener that's listening in on this and is thinking about having surgery, how much easier is it for a patient to go to sleep and have surgery than stay awake and get local anesthesia and have surgery.
Yeah, the concept
I mean, it's just,
that
it doesn't make sense to
Right.
me how people want to get tortured and not just go to sleep, be comfortable, have your surgeon do your thing, wake up, and you'll be a lot better off, right?
Right. So let's talk about the surgeons that want to brag about a practice that says, I don't need anesthesia, I'm just going to do it without it. With the right anesthetic, it is, first of all, the same. Yes, you are adding some anesthesia, you're adding the comfort of the patient, but you're also changing the way the surgeon can operate. Mm-hmm. There is no reason why a surgeon should wear both hats on an operative day. For the surgeon to be
truly focused on
on the surgery, he should not be delivering oral medications or directing some kind of RN or nurse to deliver a conscious sedation medication, because he truly is responsible for now the airway and the life of that patient. Mm-hmm. So if something were to happen, he better be ready to defend himself. Now, for the perfect surgery or the perfect outcome, the surgeon should be 100% focused on what? The surgery.
Absolutely.
Yep.
And so for him to punt the anesthesia and say, I can do both, why is he doing it both? Is he doing it because it's a marketing ploy? Because, oh, look at me, I'm so great that I can do both? Mm-hmm. Or is it just because...
Save money.
Well, I didn't want to say it, but yeah. It's just because, one patient will say like, well, I can go to surgeon A or surgeon B, who's a little bit more expensive.
The surgeons that do that, they're going to say that the patient recovers faster in a setting where it's local with sedation. And I would argue that if the general anesthetic is done correctly, they can recover just as quickly and be more comfortable. But let me know if I'm wrong.
Right. So I've done so many cases in my career with oral medication. So who would be best to know actually how an oral medication works? It's me. Mm. Right. You would say, oh, I just gave him a pill and all of a sudden, bye-bye, and the patient was in La La Land and I was able to do the liposuction. I mean, wow, it was great. They even stood, they even raised their arms. But that patient comes home and the half-life of those oral medications are way longer and more detrimental to that patient coming home for a problem at home in recovery, falling in the car. I didn't even remember coming home.
Yep.
And as opposed to what I can give, where it's short acting in an acute setting where I am actually in control of that patient, where they can get up, get out of the wheelchair and walk. We want a patient to be able to come home, use the restroom, be aware of their facilities, be aware of what's happening. God forbid there is a problem. Instead of just going home because they've overdosed themselves on some Halcyon, and even though the surgeon says, great, I didn't have to pay an anesthesiologist because I kept, the anesthesia portion of that. And then all of a sudden the patient's home and says, I didn't remember 3 days.
Yes.
Wow.
And so the patients don't realize that because sometimes they just see dollars and they're happy because they didn't have to pay.
Sure.
And they got away with it. But let's talk to the surgeons that do that and see how many times have they had an issue. Because now the surgeon goes home and he better follow up with that patient or have his staff follow up with that patient to make sure that patient is okay and woke up the next morning.
Listen, I've done cases under local because patients are too scared to have anesthesia, and I'll say, fine, I'll do it. It's miserable for the patient. The patient's just uncomfortable. It doesn't matter how much pain medicine you give. Mm-hmm. It's just a lot better, and I think the outcomes are better when you have anesthesia.
What are some of the challenges in particular that you've faced as your role in an anesthesiologist and in an aesthetic setting?
I mean, the aesthetic setting, obviously comes with its challenges because I always kind of joke with family friends that as soon as somebody, a patient has 2 ways to get medical care in this country. They have insurance or they pay cash. Mm-hmm. And as soon as a patient pays cash and they're about to hand somebody $1, wow, that patient feels like they own the surgeon and they own that whole experience. And that experience better be really good. And we are in a service industry where we have to continue to provide high quality service, because at the end of the day, that service industry is a referral based service industry. Just like as how do I keep my job, I have to keep on doing a great service.
Yeah.
The patient, you need more patients based on referrals.
Right. And so all of our patients were nauseous afterwards, and they told everybody else, yeah, listen, surgery went really well, but you're going to be nauseous as all get out. That's a big fear for patients. Patients almost dislike nausea more than pain, because the pain we usually can control. Nausea sometimes is very difficult.
It's horrible. And so I have a fair amount of techniques that I do for nausea that are that are pretty magical. And again, where I go to other centers where I do something and they're like, oh, another anesthesiologist had this patient. And this happened, again, probably about a month ago. It was a spine surgery. Another anesthesiologist did the spine surgery. I finished my case. A nurse called me and said, God, patient is just, once you're having neck surgery, really the last thing you need to do is start vomiting.
Yeah.
And so the nurse said, what can we give them? And I said, have they tried this? And they go, oh, we don't do that. And I said, well, we're going to do it today.
Yeah.
And what does that mean is that I'm now in the recovery room with the patient, monitoring them, doing whatever I'm doing. And 5 minutes later, patient's like, this is night and day. So I know I have tricks in my bag that I do, and patients ultimately do better.
Yep.
So it's not that I'm not wanting to tell any anesthesiologist that asks me. It's really just, you just have to want to do it. It takes time. It takes effort. It's harder to provide an amazing sedation, anti-nausea anesthesia than it is just to put a quick breathing tube, turn on some gas, and say, call me when the case is done.
And that's it. Let's transition to that for a second, because a lot of people ask me this, and perhaps I'm ignorant to this, so maybe that's why I'm asking you. When you do put people to sleep, like we did 2 cases yesterday, people ask me, so what am I going to sleep with? What are they using? So there's gas, so there's inhalation anesthetic, right? And then there's IV anesthetic. And just in a short, and without getting too technical for the listeners, what do we normally use to put people to sleep, and how do we keep them asleep, and how do we prevent that nausea and vomiting as well, in a simple layman's kind of term, if you can?
Right. So for most of the cases that we do that are, I'm going to call it either a combination of IV infusion anesthesia, that people will like to say it's like twilighty, versus a general anesthetic. It's like a combination of both.
Right.
So my general anesthesia is a secure airway, but at the same time using mostly IV medications to try to avoid a lot of the inhalational agents. Not that the inhalational agents are bad. With time, of course, historically we start with the ethers, and then we have all the generations of different gases. They all have their different reasons why you would use one versus the other. The IV infusion medications tend to be a little less disruptive to certain aspects of the body, and definitely some of them are way better for nausea purposes. That's why when someone says like, I had a colonoscopy, that was great, just do that. And so the more information I elicit from a patient, the better that anesthesia will be. When a patient says, I had this, and that's why I ask, like, even when it comes even to the IV, like it's not a failure on my part to say to the patient, when you get a blood draw or when you get an IV, where do they usually go? This isn't because I don't know how to start an IV or where to find veins. Most of the patients will say, this is where they go. This is the success. You're only just using the information to make the best experience. Why should I start or try an IV 10 times? And then the patient says, oh, they usually go here. That's the only good vein.
No, it makes sense.
And so, but with that analogy, it's the same with anesthesia. So I say, how have your last anesthetics been? What have you had done? And what have they used?
Yep.
I mean, those 3 questions can be so powerful for me to change the outcome at the end. And it's not a failure on me to ask, have you had this medication, that medication? So to answer your question, yes, it is a combination of IV infusion medications. Yes, lots of anti-nausea medications. There's no failure in using any of this. And then ultimately you transition into the smooth wake up. And so ultimately you want a quick wake up. Some surgeons are, what makes a good anesthetic is patient goes to sleep really fast, patient wakes up really fast, and patient walks out of the operating room and the surgery center fast.
Absolutely.
But that right in there, that's like the perfect storm. Sometimes let's say it doesn't happen, but you really have to hit all those points to make that happen.
Yep. All of the cases that you've seen, I know I can think of a few, but any, would you say memorable experiences or success stories that come to mind when we say, what was one of my best patients or experiences since you've been with us or in cosmetic surgery?
Sure. I mean, obviously we live in this town, so you don't have to throw a rock very far to hit a celebrity. But so that's always fun and great, and it's excitement in the OR on that day, and we do a fair amount of celebrities. But the reality is that the everyday patient is my most memorable story, because those patients are the ones that have saved their money for time and they've been just, ever since high school, I hated this, and now I'm 30 years old or 40 years old, and I'm going to change that. And they've done their research with both Dr. Danielpour and Dr. Layke to say, like, this is the person that's going to kind of take that anxiety and the thing that I don't like, and they're going to change them. And we see that happen, right? So ultimately, when you say, maybe on your end, what is it that you like about being a plastic surgeon, is that immediate gratification. I have that immediate gratification of, wow, like I was there to be able to be along that ride with them. In training, I did a lot of epidurals for pregnancy, for delivery for moms. I love that. I mean, memorable in that sense, because you just knew that you were a part of a moment of that patient's life, and you were helping mom out in such this like magnanimous
and it's
way.
Be an amazing experience or
a bad experience.
Yeah.
And so like memorable experiences. And to be honest, I remember a lot of patients. I mean, like some people have faces, names, and because I'm actually bonding with the patients on that kind of secondary, tertiary level, I actually know about their lives. So I might not remember their faces right away, but I do remember so much. So yeah, but when you're with people that make the experience better, it really changes the dynamic of how we work, how our lives go. And I think it's representative on the patients.
Yep. It's like any business you walk into, right?
And so the patients pick up on that pretty quickly. And so your business is successful because you've created that environment. So it really starts on the top from you guys.
If you like this video, you're going to love this one.
It was really interesting for all of you BBL lovers out there, the Brazilian butt lift, is that there was an 86% increase in the buttock lift